What are some of those other things that you might recommend to women if they come in and they haven't seen improvement with the things that they can do?
I'm a big fan of low intensity shockwave therapy for both men and women. Basically a handheld device that we use that delivers high intensity pressure waves, almost like sound waves, into the tissue. Very well studied now in men for improving erection quality.
We can open that conversation about how this is such a vital sign as well. Sexual health is a longevity marker.
A number of big studies now that show strong correlation, at least, between sexual health, sexual activity, and longevity in both men and women. There was a 2020 study out of Journal of Sexual Medicine, which looked at 15,000 people. It followed them for, I think, up to 11 years and found that people who had sex at least once a week.
In this episode, Dr. Durst is joined by Dr. Amy Killen, a nationally recognized expert in regenerative medicine, hormone optimization, women's health, and longevity medicine. She's becoming a leading voice in helping women optimize not just lifespan, but health span as well. And we are so excited for today's conversation. Let's jump right in.
Welcome back to the channel. It's Dr. Durst. And today I have an expert with me, Dr. Killen. She is a specialist in regenerative medicine. After many years in acute care medicine, she switched her focus to focus on longevity, women's health, optimization, but regenerative medicine. And so today we are going to deep dive into all of the things with Dr. Killen. So welcome.
Thank you. I'm happy to be here. You and I seem to have similar paths in our medical careers, so it's fun to talk to you.
Yeah, and it's actually very interesting because then you spend years, right, in acute care and emergency medicine is what you specialized in as well. And then you just find a area of medicine that you become passionate about and a huge gap that exists, right? And then you pivot. And It ended up being probably a larger gap than you anticipated when you first did it, right?
There has been a lot to learn, but I left emergency medicine in 2013. So I've actually been on this kind of other side of medicine for 13 years at this point. So it's been really fun to be along for such a long time.
Yeah, and I think that you are, paving the way for innovative medicine and physicians that have to branch out of traditional medicine. They become innovators in the field, and entrepreneur is part of that, right? And you even have some business interests that we're going to dive into as well, because you put it into practice and then you realize that there's more and more of a need for it and not enough people doing it, right?
Yep,
So,
absolutely.
well, awesome. Well, I know that you have a focus on regenerative medicine, on optimization for women and women's health. So tell me a little bit about how that became a large focus of yours as you started to branch out into regenerative medicine.
Well, I treat both men and women in my regenerative medicine practices and in my clinics, but I speak more when I do content creation on stages about women's health more, because in the last 3 or 4 years, I've become more interested in women's health. I think partially because it's just so kind of understudied and, we are different from men and there's some interesting things to talk about there, but also because in 2023, my mom, who was 76 at the time, she fell and broke her hip. And I kind of saw what happened through her journey. She broke her hip. They took away her estrogen, even though she was on it and she needed it. And there were just all of these downstream effects that I saw, kind of the lack of information out there among other doctors around hormone therapy, often a lot of lack of information around even what we can do with regenerative medicine for various things in health. So I just became even more excited about talking about women's health specifically, but I do treat both men and women.
Okay. And so I'm there with you, and I never want to leave men behind because I do feel like they're left behind too when it comes to looking for solutions that don't involve medications and surgeries. But I do think that with the big push towards educating women more, and women's health and perimenopause and menopause has been a big push recently. And so that really ties into how you got started with it, is with bone health. And I've seen some videos of you talking about your mom with that. And so if we talk about the gap that has been present for women for 20 years, What do you think about the recent lifting of the FDA black box warning and the public, I guess, excitement about that?
Well, I'm very excited that the black box warning has finally been mostly lifted. It's still there for endometrial cancer, which is appropriate. We need to have that. If you need estrogen, you need
Yeah.
progesterone. But, I've been treating women with hormones since 2013. So I've been doing it a long time. I've been talking about it for a long time. And it's one of those things that's so funny. Earlier in my career, when I first started talking about, the body identical, bioidentical hormones, so
Mhm.
many of my colleagues who are still in the hospital or in the ER, they just laughed. They were like, "You're harming people. This is voodoo medicine. This is not real. Like, you're giving people cancer." And I kind of put up with that, for a decade. And so it's nice now to see finally, like, a lot of these traditional kind of allopathic medicine physicians are coming around and realizing that this was all, we actually have had evidence for this stuff, this hormone therapy for decades that we just weren't looking at. So I'm very happy to see that the FDA has come on board and that women are getting, easier access to hormone therapy.
I think so too. And what I've kind of come to realize is, again, specialists like you that have branched out of traditional medicine and did it a long time ago have been filling that gap for the last 20 years. Since 2013, but there were actually innovators way before
Yeah.
you or me that had kind of pushed, and they were definitely not popular. And actually, I've seen some legal action against a lot of those as well in the early phases of it. But I think that when it comes down to that and that lifting, I think people get confused that the FDA approval means everything, right? And guidelines. But I think I've seen you talking about it too. They're guidelines, but obviously physicians such as yourself have deep dove into science without somebody directing it. And physicians can do that. So I think maybe even just talking about your thoughts on FDA guidelines and the slow change with the institution versus the physicians that are just actually practicing based on science. Because it might help clarify that for some patients that get confused. What
Yeah.
are your
Yeah.
thoughts on that?
There's a big, the FDA is here to provide guidance on how to use and whether we can use certain medications. Like, that's their rule to, make sure the medications are safe and approved. Once they approve a medication, for instance, estradiol, which is the body identical estrogen
Hmm.
that most of us use these days. Once they approve a medication for any reason, then physicians can use that medication off label for other conditions if we think that it's appropriate, if we have, enough clinical evidence to support that. So, for instance, estradiol is FDA approved for preventing osteoporosis, and it's FDA approved for
Hmm.
treating hot flashes or other vasomotor symptoms. It's not FDA approved for other things like cardiovascular disease risk reduction, or potentially dementia risk reduction, or any of the other indications that we as physicians know that it or think that it can be helpful. It's not approved for those things, but we're still allowed to prescribe it for those things. So fully within our license, fully acceptable by everyone to use our clinical judgment when we prescribe these medications, as long as they're FDA approved.
And it's a good thing that physicians continue to do that and deep dive into, the research and the benefit, even without that guidance overall. And also just the prevention alone, I've heard you talk a lot about the bone prevention, but when it comes to hormones, and again, I always tell my patients that it's like only hormones and vitamin D that are really going to keep your bones healthy. But you have a lot of science, and you have, because of personal reasons, really dove into the bone prevention. Do you want to talk a little bit on that?
Yes, I mean,
Like the percentage? Yeah.
progesterone, testosterone are all three bone builders or help maintain bones.
Hmm.
And in women, when estrogen and progesterone production, falls off that cliff at perimenopause, where your ovaries can't make anymore because you run out of eggs, the one of the first things that we see is bone loss. Estrogen plummets, and then very quickly we start seeing bone loss if you're not actively working to preserve bone. So certainly all the lifestyle pieces, resistance training, jumping, axial
Hmm.
loading, diet, all of that is really important. But then also estradiol is one of the best things, one of the probably the best medication tool that we have for not just building bone, but building healthy bone. And I think that there is a difference there. Some of the medications that are out there can make your bones look denser, like on the DEXA scan. So you can it looks like you've got strong bones because you've got a lot of mineralization, but the bones are actually not that strong. They're actually more fragile in some cases. But estradiol is amazing for building healthy bones. Progesterone and testosterone are also supportive as well. And you can start estrogen for bone health at any time, and it's effective. So even if you miss that 10-year window after menopause onset, you're in your 60s or 70s or even 80s, we know that the estrogen can still positively affect bone.
Well, I just had a patient in yesterday who was 66 and has not been on hormones. So we had that discussion too. But we actually did an M2 factor screening and she was there. That's how she came in. So her question then and when she came into the office was, can I start now? Because of that 10-year gap that everyone talks about. So I think that's important. What you just said is that, of course, at any point assessing risk, so you assess risk, but also then you're going to still do it because it's helpful to prevent at any age.
In older women who haven't been on hormones for, a decade or more, I think of it more as risk factor, as more as like side effects than I do risk. I don't think that there's a lot of risk in using, as long as we use the right type of hormones in these patients. I don't think there's a lot of risk in using the hormones. However, you can have side effects. So, if you start at 7 on estrogen, you may start having vaginal bleeding or sore breasts or, water weight gain or like side effects that maybe you don't want to have as a 70 or 80-year-old. And then the downside to waiting too long, even if it's so certainly not your fault because you didn't have access to hormones, but the downside is that there are some things that don't respond as well to late start hormones, like the cardiovascular system and the brain don't seem to respond as well in late starters as early starters. So, there are benefits in those categories. But for things like the bones and the pelvic floor, they seem to respond anytime we start hormones. So there are benefits to different systems in different ways.
And then there's a big focus on estrogen, and that's just one part of it. But I know that you talk about all of them. And so, what other, like progesterone, when it comes to when do you start having those conversations with patients? Because that's a perimenopause drop. And so, because you don't hear as much about progesterone, right?
Yes, I know progesterone is wonderful. I think of it as this kind of chill pill. In most women, it will kind of, reduce anxiety and help you sleep and chill you out. Some women do have the opposite reaction, but most women really like progesterone. And thinking about it in perimenopause, as your own production starts to go down, progesterone is the first one that goes down generally in perimenopause. Estrogen can actually go up, kind of chaotically in perimenopause. So adding progesterone then can really help with sleep and with some of those quote unquote estrogen dominant symptoms that we sometimes see. But progesterone, honestly, I use it even in younger women. I use it for helping with PMS symptoms, helping with PCOS symptoms and side effects, helping with migraines that may be cyclical. Like there's so many uses of progesterone, and it does not get as much airtime as estrogen, but it should.
It should. I have a lot of women that will not go anywhere without their progesterone. They're leaving on vacation and they're almost out and they will not go on vacation without it because, again, they can't sleep if they don't have it.
Yeah.
And then I also think that with the we always just say it's the feel-good hormone. It's sleep and mood. And it really does help a lot with that. But it doesn't get as much airtime, which I'm surprised about. And then testosterone. And I've heard you talk about this a lot. And I think that it's gaining some momentum, but obviously it is a way underutilized. And so, again, talk for a few minutes on how you're approaching testosterone in women.
Well, women make more testosterone than they do men. And at any given point in our lives, starting from puberty onward, we have more testosterone in our bodies than we do estrogen. So the idea that we wouldn't want to replace it when levels start going down is, to me, kind of absurd. I don't think that all women need testosterone therapy, but I do think that many women benefit from it, especially, starting around age 40-ish, depending on the person. we oftentimes will see improvements. As testosterone is not FDA approved for women, so we don't actually have an FDA approved version, but doctors have been giving testosterone to women for 50 plus years. And it's actually quite safe as long as you use it appropriately. It can help a lot with like sexual side effect, sexual problems, low libido, arousal problems. And that's what it's most known for in women. But I think a lot of us who use it, frequently will also say it also can help with mood and motivation and maybe even muscle building. And there's a whole lot of other things that testosterone can likely do in women.
Yeah, brain fog,
Yeah.
just overall like zest for like even sleep. I find a lot of women have
Yeah.
improvement of sleep with testosterone. So, and again, it doesn't get as much airtime, but also like if you look back at the guidelines and them not recommending it, the studies that link in the guidelines actually do list all the beneficial effects of it because, obviously sex drive is one of them, but it's satisfaction. It's like increased frequency, increased orgasmic strength. So there's all kinds of stuff, and it kind of comes down to now the sexual pivot. And so I know you do a lot of sexual wellness as you are also addressing regeneration and optimization in men and women. But when it comes to women, I see a big now almost where they're taking control. Like when I first started doing sexual wellness 7 years ago, men would come in and they would be very decisive about wanting to do. And I know we can talk about that. You do regenerative medicine and sexual function, regeneration with men too. But now I see the push, there's more women coming in wanting better sexual function. And so are you seeing that as well?
Yeah, I definitely see more women. I mean, I see both men and women now both coming in, which I totally agree. Back when I first started, it was mostly men because men knew that we had at least Viagra, like we had a tool for them. So they would come in and they would present the problem and they thought that there was a tool. I think one of the big problems is that women haven't really thought that we have any tools that can help them. Like, why would they come to us and ask for help if we can't help them? And certainly, as you very well know, we do have a lot of tools that can help both men and women now outside of Viagra, including shockwave therapy or stem cell injections or lasers or, RF or various kind of devices and things.
Yes.
But I think that the conversation, luckily, I think social media is helping. Women are finally learning that there's actually some things that we can do and they just need to ask for it.
Yeah, no, I think they are finally realizing number one, they can have the conversations because they had nowhere to go for conversations. It wasn't like they would talk about hot flashes. They just weren't talking about like vaginal dryness with friends. And now I think those conversations are more open. So I do hope that black box warning, or at least the press time overall that it's getting for perimenopause and menopause for women, very empowering.
Yes.
And so when it comes to sex drive, because again, that's just one part of what we're talking about. Like, because we both, I think, approach, and I have been watching you for years and, and just watching even social media videos and addressing all the things, but also sex drive is just one part of it. But how do you view that as it's a vital sign for women or men that sex drive is really indicating that there's something else. So do you want to talk or, let us know what are those things that you're thinking about when somebody comes in and they have a low sex drive? That's just one part of, the big picture, but still the other things that you might be thinking are going on health-wise when they come in with just a low sex drive.
Yeah, low sex drive it can be from so many different reasons, and it can be complicated. I think low libido is. I remember whenever I ask women, especially midlife women, how is your sex or how's your libido? One of the most common answers that I get is what libido. Like they're just like, well, I don't even have libido. And so but it can be anything. It could be stress. It can be relationship problems. When I think about sexual health, I think about kind of the 6 types of health that influence sexual health, including libido. So certainly physical health is going to play a role. Do you have enough testosterone, estrogen, and all your other kind of hormones, thyroid, is that in the right place? Physical health is one of the 6 types of health, but you also have social health, so relationship health with your partner or partners, your emotional health, and your mental
Mm-hmm.
health obviously play a big role. Depression is a big contributor to low libido, PTSD, any kind of sexual trauma. Spiritual health is a big one, I think, as well. A lot of people have I live in Utah, and there's a lot of, the LDS church has sometimes put a lot of shame, like people feel guilty and shameful. And so that's a big piece of that puzzle as well. So really looking at all the different, and even environmental health, which is the sixth one, endocrine disruptors, things in the environment that
Mm-hmm.
might be playing a role. All of those things influence libido. And so you have to start and think big, like what is possibly causing it first.
Yeah. And again, I think that this might be a good time to even talk about the business, because you have your practice in Utah that you've had for some time, and that encompasses women's health not only, but you do men too. And what are you doing in that Utah versus, let's talk about Humanot after? And is that
Yes.
how I pronounce it?
Humanot.
Because
It's like astronaut,
human,
but for
okay.
humans.
Okay.
Yeah.
Because then it branched out to even more and more of a longevity. So in Utah, you are treating men and women and you're doing a regenerative practice, right?
Yes, exactly. I have two practices in Utah. One is the one I primarily work in myself, which is regenerative
Okay.
practices. It's just stem cells, exosomes, secretome, anything that we're injecting regenerative medicine wise. I have a partner in that. It's actually his practice, and he does musculoskeletal injections, neck, back, joints, things like that. I do, sexual health, so sexual injections,
Mm-hmm.
skin and scalp, and then we also have some intravenous options. So we essentially do kind of these big stem cell, we call it the full body stem cell makeover. We do these big procedures that people travel in from kind of all over the world. And when we essentially inject all of the major joints, the scalp, the face, the sexual organs, all at the
Okay.
same time. So that is where I spend some time. And then I also have another practice here in Utah, biorestoration, which I've had for many years. Big integrative medicine hormone practice, Utah's largest bioidentical hormone practice for
Oh,
more than a decade. So those are my Utah ones, and then I also have some other practices for Humanot, which is Humanot Health. I'm the chief medical officer and the co-founder of that. It's a health optimization franchise, and we have clinics in Austin and South Florida, and we're opening Dallas in a couple of weeks.
awesome. And so that's more focused in on longevity. And
Yeah, that
so,
one is a combination. It's health optimization, longevity. So we are doing hormone, replacement, hormone therapy, hormone optimization therapy, as I call it. But we also do peptides. We do regenerative medicine, so stem cell injections. We have a whole gym, and we do kind of full assessments, lots of advanced diagnostics, and we put together, care plans that are very personalized for everybody.
okay, awesome. And so really that actually kind of brings to the point, because I think people come into our office and they'll come in for hormones. So you get a lot of patients, I'm sure, at both the
Mm-hmm.
Utah practices and Humanot that are coming in for hormone, because I consider the core, but
Yeah.
that's just one part of it. And so when you talk about peptides, a progressive area of medicine, but what kind of peptides are you mainly doing with that longevity? I'm sure it is, variable depending on what they're coming in for, but talk about peptides for a moment.
Yeah, I mean, we have access to a number of different peptides. We use a lot of the FDA approved peptides, like the GLP-1, agonists, which
Mm-hmm.
of course is Ozempic and Wegovy and those medications. I think those are phenomenal drugs. I think those are, sort of the longevity drugs of the future, even though they're not approved for that yet. But we use a lot of that in combination with hormone therapy, which works so well
Mm-hmm.
synergistically. We also use some other peptides, like some of the growth hormone, secretagogues, so the peptides that kind of help you make more growth hormone, which is great for
Mm-hmm.
healing, sleep, and building muscle and mood and all of that. We have a number of kind of healing peptides that we'll use
Mm-hmm.
sometimes, BPC 157 or
Yes.
thymosin alpha or some of that sort of immune modulators. So, we have a bunch of different peptides, but I tell
Mm-hmm.
people that not everyone needs peptides. I think that they do have
Mm-hmm.
some great benefits, but they, to me, are more like the icing on the cake. Like you want to get the foundations with your lifestyle. I think hormones are pretty foundational to me.
Mm-hmm.
I'm not sure if you agree with that. And then to me, peptides are out there, but like you got to get everything else right first in general to see a lot of benefits from those.
No, we're on the same page with that. Like we have that conversation frequently because a lot of patients will come in just wanting peptides with us, but we
Yeah.
have to really talk about the hormones. And I just say that's the core. You have to optimize. And I agree with you. There's a lifestyle component because these are just tools that we help. But like, again, if you optimize hormones, but they're unhealthy, so it's their part of it too. I agree. And then
Yeah.
peptides, I absolutely agree. That's the icing on the cake. That's the next step. So we can just take everything else to another level depending on what they want. I was recently asked if I could choose one peptide that I couldn't live without. Which one would it be? And
Ooh.
I had trouble with that one, but I wonder if you had to just choose one peptide, like the FDA was going to eliminate our ability to use any of the others, which one would
I mean,
you
I would use a
choose?
GLP-1 agonist. I would use, probably right now tirzepatide. I think retatrutide when it gets approved. But any of the GLP-1s, I think are heads and tails above all other peptides in my book, because we have a ton of data and there's just so many use cases for them.
Yes. No,
What was your answer?
well, I actually was, I really couldn't do one, but I love myself. I love melanotan too, which I was like, that wouldn't be the great physiologic one, but I actually love that one. So
Yeah.
it wasn't a really good answer because I would choose something that was more optimizing for me physically, but I love melanotan just because
Yeah. That's
you
so
don't
funny.
have to
My
use it that
husband loves
often.
melanotan too, and I have a bunch of my daughters are 18, so they're graduating from high school this summer, and sometimes I'll get messages from their friends who are like in college, and they're like, "Hey, can you write for me some melanotan too?" Like somehow it's
Oh.
gotten into the vernacular of like young people, and people are asking for it now, which is so funny.
Oh, yeah, no, it is amazing. And then actually young people in general, there's a big push towards the peptides in young.
Yeah,
I've had a lot of younger patients recently that, again, you almost get on the phone with them and you think maybe this is too early.
yeah,
But it is like a stacking that you can actually kind of cycle on and off. So I think still having a person such as yourself doing it the right way or an office doing it the
yeah,
right way is still where they should end up instead of just online purchasing them. So, but
agreed.
there's some interesting stacks going on for sure. So, longevity, data, and sex, because again, sexual wellness is, I think, something unique to us, not unique to us as if we're the only ones that are doing it, but you see a lot of physicians that are talking a lot about perimenopause, menopause. They talk about hormones and peptides,
Mhm.
but there isn't as much out there as far as sexual wellness,
Yeah.
longevity. And so you look at it as a longevity marker as well. And
Yes.
so so tell me a little bit about that, or just so that I guess we can open that conversation about how this is such a vital sign as well. It's not just overall feeling, it's not just prevention, which is a huge part, but that sexual health is a longevity marker, right?
Yeah, absolutely. I mean, we have, a number of big studies now that show strong correlation, at least between sexual health, sexual activity, and longevity in both men and women. There was a 2020 study out of Journal of Sexual Medicine, which looked at, 15,000 people. It followed them for, I think, up to 11 years and found that people who had sex at least once a week had a 50% lower all-cause mortality rate compared to people who are not sexually active. So, 52 times a year for 50% lower mortality rates. And of course, this is correlation. There's a lot of factors that are coming into play here. But I do think I think that sex and sexual health is a biomarker of health. And I also think it's a contributor to health. We know that if you have a healthy sex life and you're happy and it's enjoyable, that it contributes in a positive way to, all those other types of health, just it's kind of like the opposite of before. We see less blood pressure, we see better, less depression and anxiety, better self-image, stronger relationships. We see less brain aging in the hippocampus, better memory with age. Like there are so many things that a healthy sex life seems to contribute to that would also promote longevity.
Yes, and I think that as patients have gotten older, sometimes it's actually minimized that, it's kind of normal that their sex drive would lower or that sexual activity isn't important. And have you seen that as well from, again, traditional medicine, probably? Because we have
Yeah.
patients that'll come in pretty um, almost depressed and anxious over the fact that they've been brushed off and that sex isn't a part of what should be going on once you get older.
Yeah.
You've
I mean,
seen
and we
you've
know
seen
that
that
for
as well?
women, I'm sorry, I didn't mean to cut you off. Well, for
No,
women, we
no.
about a 30% of women tend to just kind of stop having sex during that menopause transition. Some of them get back to it, but some of them don't. And I think it's interesting in that sometimes they don't really care. They're fine. They're happy that that phase of their life is over. And then sometimes they do care. And so, we get both categories of women
Mhm.
who are changed by the hormonal changes and then just kind of take the life changes that happen. And then they don't, sometimes they don't know what to do with their sex life after midlife.
Yeah, and I think that when we do a lot of couples as well, and I'm sure you do too, because you end up optimizing one and then the other one comes and you do both men and women. And so that is a unique part of our practices. But I think that it has to be aligned is my big thing. So if one is off alignment with the other one, then that causes issues in the long run. And so it really is a matter of them. It's not like we're seeking, patients out just because they have a low sex drive, but they're coming to us because it's something that's bothersome for them. I
Yes.
had also seen a couple like books on sex by really great authors, but they kind of minimize that after 50 it has to be different. Like it has to be that dryness is normal, lubricants are necessary, that orgasmic strength is something that is going to change and maybe just connection you should focus on. But
Right.
again, for you, do you think that it has to change with everything that you do from a regeneration standpoint? Do you feel like it has to be any different?
I don't think that sex has to change. I certainly see that it can change. And then, if it does, it's good to
Mhm.
embrace that. But yeah, we have great tools for keeping the vagina lubricated, for keeping the pelvic floor strong, for, keeping arousal high, like, between systemic hormones and local therapy with things like vaginal estrogen or testosterone or DHEA, plus, shockwave therapy or some of these other devices that can be helpful. Like we have so many tools now. So I think that we shouldn't expect that we are going to fall apart after a certain age. We should expect that we're going to stay strong and we're not going to fall apart. And we should, take action and try to get to that point.
I love that you can really simplify some complex topics and actually make it very understandable for the for patients in public. I've seen that already in your videos, and you just took it and did it a couple times right here. But yeah, no, I agree that. So what you're saying is yes, it does end up changing, but it doesn't have to, and the tools are available. What are some tools that women can do? And again, we talk about it as well, but I think them hearing it over and over again, like what are some of the tools that they can do that can improve lubrication, pain if they have it? Urinary incontinence is another big one, and probably the only one we're allowed to talk about in traditional medicine, right? So, yeah,
Yes.
yeah.
Well, one of my favorite tools is vaginal estrogen, low dose vaginal estrogen. I think all vaginas need estrogen, and if you don't make it,
Hmm.
then you should take it. That's it. Like essentially from when you go through puberty, your vagina, pelvic floor, vulva, it needs estrogen. And, you make it all the way up and through, till menopause, and then you stop. So at that point, you should consider taking it, even if it's just low dose vaginal estrogen, which is very safe. And as you know, very effective.
Hmm.
And then I also think that there's, staying on top of like making sure that you have a strong pelvic floor, that you're
Hmm.
exercising in the right way, that your pelvic floor is not too tight. And sometimes it can actually get too tight and strong, which can be
Hmm.
a problem. So understanding that is important, and you can do that at home or see a physical therapist to get assessed. Those are some simple kind of easy things outside of just the normal things, the healthy lifestyle pieces that you can do at home with the help of a
Hmm.
doctor.
And then regenerative procedures that you would add in there. And again, I think that there's always, and I agree with you, and I think we approach it the same, there's going to be their part of it, right? That they're doing all the healthy things, the lifestyle issues. And if we can do exercises and get anything that improves without hitting the medical aspect of it, but then you have a strong science-backed medical practice that actually adds other things on for regeneration. So what are some of those other things that you might recommend to women if they come in and they haven't seen improvement with the things that they can do?
Well, I'm a big fan. I mean, certainly I'm a big fan of low intensity shockwave therapy for both
Mm-hmm.
men and women. And it's an in-clinic treatment, but super easy, not painful,
Mm-hmm.
basically a handheld device that we use that delivers high intensity pressure waves, almost like sound waves into the tissue.
Mm-hmm.
Very well studied for improving musculoskeletal health and kind of hastening healing. Very well studied now in men for improving erection quality, and some emerging studies finally on women.
Mm-hmm.
Like you said, it's interesting. In women, the studies that have been done either for stem cell injections, PRP, shockwave therapy, it's all for something else. It's all for stress urinary incontinence or, lichen sclerosis, or like it's something that's not just make sex better. Like it's never just
Yes.
like pleasure.
You're, yeah, you're not allowed to actually say that or even suggest it for women yet.
Yes.
But
Yes. So
yeah.
you have to look at the study. So there are other
Mm-hmm.
peripheral studies that suggest that these therapies, certainly injecting, PRP or some sort of regenerative modalities like stem cells or, other secretome products like growth factor products into
Mm-hmm.
the vagina, the clitoris, the labia, like all of those I've found can be really helpful for women in the right cases. And then I also like intravaginal red light therapy, which is a fun kind of home thing that I don't know if you have your patients do that, but I like some of the home devices that they can use on their own, and they're pleasant, and I think they can be helpful as well.
I haven't used that yet, but I've seen those recently. Like I probably had seen more of that recently.
Yeah.
And again, I know that you've talked and have some radio frequency that you'll do as well, intravaginally and external, and that's is
I don't
one
have an
modality.
interest to do more of it. The machine I had was pretty unreliable, so I kind of have stopped. But I did radio frequency for a while. I've done laser, like CO2 lasers as well for a while. But now I'm leaning more on shockwave therapy and just kind of regenerative injections in combination with hormone therapy.
Yeah. And I always like to do combinations. So, like the regenerative injectables when I'm doing anything else. I do after we'll talk a little bit because I do have like a really kind of unique take on lasers. And I just realized recently that physicians, probably the public as well, and it was at a cosmetic gynecology society meeting recently that it became clear that lasers to physicians and I think the general public, they almost think of it as CO2 and ablative, but there is actually one that we do and even externally that is actually just a non-ablative heating mode,
Mhm.
which I really like to pair with injectables because then you're actually heating and
Yeah.
regenerating, telling the entire tissue and then adding in that, that
Yeah, we have one of those
injectable.
as well, actually. I do like that. It's not
Yeah.
painful. There's no worries of burning or things like that.
Yeah, and it's really simple, no downtime. When you talk about stem cells versus exosomes, because it sounds like you guys use a lot of that. And we don't advertise it as much, but our patients, like we are having those conversations when they come in, and often patients are coming in for that. But when exosomes became, what are the reasons why you would use an exosome versus stem? And like, how do you feel about those two products and the differences?
Yeah, I mean, I think that they're both useful, and luckily, in Utah, we have a little bit of more flexibility in terms of what we are allowed to inject.
Mm-hmm.
Stem cells are the cells themselves. The exosomes or other types of extracellular vesicles are going to be, I think of them as like little messenger bubbles. These are the
Mm-hmm.
bubbles of information that are released by stem cells that have within them like growth factors and messenger RNA and some of these signals that then when
Mm-hmm.
your own cells take in that exosome, it changes how your cell behaves. And so it can make your cell act like a more youthful version of itself. Some of the benefits
Mm-hmm.
of exosomes, I think, are that they're so small that they can actually get through certain tissue. They can get through your skin. If you put them on your skin, they can get into your brain. If you
Mm-hmm.
put they can kind of navigate the body a little easier than stem cells. And because they're not live cells, there's some differences there in terms of how we get them and we can use them. But honestly, we don't have, at least for like sexual health and really even for skin health, we don't have like comparative studies that really look at if you use
Hmm.
mesenchymal stem cells versus exosomes versus some other growth factors versus PRP versus, people are always asking me, well, which one is better and how much better? And we don't have those kind of studies at this point.
Yeah, no, I just moved to doing probably more exosomes, and I don't know that I have. Again, it was just to me, it was the messenger, signals. It wasn't a full cell. Maybe viability was a little different, but then
Yeah.
I know stem cell is still very popular and obviously super effective. I don't think we're ever going to probably have studies that are going to support what we do from that standpoint. I don't see that happening anytime soon, but at least it is becoming
I know
a little. I
it is.
wish, but and it comes down to even when like compounded stuff. And again, being a hormone specialist since 2013, and again when it still was not talked about much, obviously compounding pharmacies play a role in that time frame. And so I know that the general public is a little hesitant, probably because societies and guidelines talk so poorly about it. I don't feel like there's any source for that fear. And if you look back, there's no adverse data to support that except for like way back with an injectable like of a spine. But what are your thoughts on compounding pharmacy, so you can maybe put to rest the fact that they're not regulated? And again, we haven't talked before, so I don't even know exactly what you do, but I can tell you that you wouldn't have been able to do what you do since 2013 without compounding pharmacies. So
Yeah, I love compounding pharmacies. I think that, like anything else, there are some that are better than others, and you do want to know what you're getting.
mhm.
Compounded pharmacies are not regulated the same way as pharmaceutical products, but they are regulated. And I think that that's one thing that the public gets a little bit wrong sometimes because we tell them the wrong information. Compounding pharmacies absolutely have to go, they have tons of accreditation that they have to go through and inspections, and it's not like they're just like someone in their garage putting chemicals together and selling them. So I use both pharmaceutical products and compounded products for my hormone therapy. For I think there are good options for bioidentical or body identical hormones from either one. So depending on what you have access to, what your doctor prefers, what your budget prefers, I think the main message here is that we just want to have more options. Like, we don't want to shut down an entire side of medicine and say that's not good when that's not really supported by the evidence.
No, I agree with you. And it sounds as if, again, you are customizing for the patient based on all kinds of variables, right?
Yeah.
And every patient is different. And so I think that one size fits all is definitely not something that we saw in traditional medicine that worked. And so you
Yeah.
branched out and did it differently. When it comes to testosterone and usage, what are the different options that you talk to women about when it comes to optimizing testosterone, and how?
Yeah, because it's always off label. Of course, we're either using, most of the time I'm using a compounded pharmacy for testosterone for women.
Yeah.
I will either do a cream or even injections, like subcutaneous injections, a couple of times a week. I used to do a lot of pellets. I haven't done pellets in the last few years, but there was a number of years there where people were doing pellets, and patients loved the pellets.
Yeah.
So but more commonly now, where we see transdermal testosterone, pretty easy to use, and then sometimes injections as well.
Yeah. And so it's really, again, customized to that patient. But you haven't seen, and again, we did a recent roundtable with women, and we're going to do that on a regular basis, just bringing women in to have conversations so they know they're not alone, but it's any topic. And so even, the idea is that we can talk about sex as well, and then make that a more normal conversation. But again, I think that customizing, every woman's different. But I will say, of the 8 women that we did the roundtable with, testosterone was the number one hormone that really made a difference for them. And
Yeah.
I wasn't sure because, again, we hear so much about estrogen, we hear less about progesterone. They're starting to talk more about testosterone, but I still think it's kind of focused on that conventional,
Yeah.
what you can use. You can use creams for men, but use them in women with no clear guidance on how to do that. But
Right.
testosterone was like the number one. Do you feel like
Mhm.
women feel that same way? The women that you're seeing on a regular
Yeah.
basis? Yeah.
I think estrogen makes a huge difference. Testosterone, I
Hmm.
think, can make a huge difference. I think it's one of the more tricky hormones because of side effects. And, it's very common to get a little bit of increased, like a little bit of increased facial hair, like not like a beard, but like a few hairs here and
Yeah.
there. I've started carrying tweezers in my own bag because I'm
Hmm.
50 testosterone and estrogen and progesterone. And I'll be at like I'm about to go on stage at an event and I'll be looking in the mirror and realize I've got like a random, shit, like a
Yeah.
hair on my chin or my lip. And I'm like, ah. So anyway, but hair growth a little bit is very common, even at low doses of
Hmm.
testosterone. And certainly at higher doses, there are other side effects that we don't see very often, like voice changes or swelling of the clitoris, which can be irreversible. So we want to make sure we don't have those. But I do
Hmm.
see that even at fairly low testosterone doses, women oftentimes it'll make a huge difference, and they just feel so good. Like it is fun to watch when it kind of clicks for them.
Yeah, and I say that old lady hairs happen anyhow because it
Yes.
was the same thing. Like even before I was not doing hormones myself, you would still have that occasional. And I think that's just an imbalance of the hormones that's happening as things
Yeah.
decline. And so, but it does actually bring to the point that you do aesthetics too, because again, my practice just kind of evolved. We were both emergency medicine,
Yep.
and that, as we know, is super fun, right? And I really did love it until I didn't love it anymore, where
Exactly.
you know,
That's exactly
yeah,
right.
it just kind of hit where it changed. Everything changed and it became, more of a customer experience, but they didn't allow you any of the tools to actually do that. And but I think that when it comes to that, you did aesthetics. I started with HRT, just feeling it myself, branching out, putting it into practice. And then I realized what a need there was. But then they would come in and start wanting Botox or something else. So I branched out to aesthetics just because I still was of the age and wanted something that I could give the skin back. And you do a lot of that too. And so old lady hairs, hair removal. And if you want to talk, I've seen some of your videos where you'll do, a laser and people don't understand the importance of that, chronic or a commitment to aesthetics and skin health as well, because it's part of it. And so do you want
Yeah.
to talk about aesthetics for a little bit? Because again, I know you're passionate about it and it's
Yeah.
just an extension of what you do.
Well, and this is it happened to me probably similar to you. I was doing hormones for patients and I would have, patients, what I started noticing is that after they started feeling better, like they're starting to lose weight, their energy's better, like they're kind of out of crisis mode from the lifestyle changes and the hormone therapy, they would
Hmm.
then come back and ask for help with either their sex life or their skin and hair. And it was
Yeah.
like over and over again. And I just started thinking like, are there other things that I can do? I'm not a plastic surgeon. I'm not a dermatologist, but like, what are the tools that I have access to that I can learn about that can help with these other two systems? So I started, back in 2013, 14, I started talking about that I specialize in skin and sex, even though, skin and
I
sex
love
are not,
that. Yeah.
they're different from each other. But if you think about them, they're actually so similar in terms of even some of the tools that we have, the regenerative tools, the lasers, the radio frequency, some of that. So anyway, I love, for skin, I tell people it is an upkeep thing. Like I know you have to always be thinking, scheduling out a couple of different types of sessions if you're able to, with either lasers or some kind of heating modalities, to help with tightening, maybe microneedling, which is super easy and very safe. But putting together stacks of treatments over the course of over the course of the year is the most effective. Prevention, obviously, instead of treating it with surgery, if possible, is helpful when you're younger, at least.
Yeah, I almost feel like there probably isn't going to be a need for surgery if we continue just to commit to. And I think we just have to. My practice was similar. They would feel better, and then it was kind of sometimes Botox, and then it was skin, and it just
Yeah.
expanded from there. But I will say that my view on that over the last probably year has changed because it's a med spa nation. There's med spas on every corner, and
Mhm.
so it's dabbling. But I think physician-owned regenerative aesthetics will stand out, or plastics or
Yeah.
derm that are physician owned and directed for sure, because I think we have sent the wrong message that it's a one and done and they can do one thing and they don't have to do
Yeah.
anything else. And it really just, we do our hair once a month, we do our nails. Like our skin turns over every 28 days too. So it's just really changing a mindset for me first, and then, our staff, and then the patients. And I think now they're accepting that commitment over time. And the young
Yeah.
girls certainly have it down, right? They understand. They're doing the
Yeah.
right things. And so queen phase, like, I know we're getting close to winding it down. But again, when it comes to midlife in women and that kind of minimization that kind of goes on, again, I don't know that I would ever accept that. But I love your queen phase. Tell me a little bit about that, because you changed how you are just empowering women to own this phase of their life.
I came up with this idea for the queen phase when I started thinking about it started with hormone therapy, and the idea that, your body is making estrogen, which is like this protective shield, protecting all the organs in your body, progesterone, testosterone, your body's making that. And so it's kind of protecting various organs, until you hit menopause. And then all of a sudden those hormones tend to drop. And so to me, that's the moment where you have to start protecting yourself. Like, you're no longer a princess. You don't have the hormones on board. You have to really make a strategic effort through certainly lifestyle, also potentially hormone therapy or other therapies to, take up that staff, that sword, and protect yourself. And so the queen phase to me is midlife on. Every day, like, we're there to protect ourselves. And I like the idea that it's empowering, and we're not going to step down. We're going to be there, doing all the things that we can to influence how we age.
And I love the positive aspect of it, because so frequently I don't like the term broken for anything. When I hear medicine's broken or we weren't broken, I just don't like that term. I just like the fact that we're empowering them to just take control. And I love that you're like, just protect yourself. And, and again, it's a different phase. It's a different way of looking at things, but just taking ownership of that phase of our life and not minimizing, for sure. One of the
Yes.
things that I noticed, and I just wanted to get a quick take on, like, again, we talk forever about a female reproductive system. Right? That's what we've learned in medical school. There's this big, huge focus on it. And you see the pictures of the female reproductive system. But again, some women never have children, or only a couple really reproductive experiences in their life, but thousands of sexual experiences. And so, but nowhere on that is like the clitoris or the vulva, the landing zones, the receptors that are hormone related there, not just production that shuts down internally after. So it's just interesting as we get to get patients and pivot that towards a sexual experience. And that is something that you do in your practice, that at least you're comprehensively addressing it. Do you do like an intake that involves that sexual function kind of assessment when somebody comes to you?
Yeah, our initial intake will have some questions, and then certainly as I start working with someone, or one of my clinic providers, then depending on what their answers are, then we'll tailor adding more questions. What I find with both men and women is oftentimes the first couple of questions they'll kind of be like, it's fine. Like, people just say, if you ask how's your sex life, oh, it's fine. Like, we get a lot of like kind of shrugs. But then if you ask more pointed questions, and ask like specific questions, then people start to open up, and then you realize maybe it wasn't quite so fine, and then you can have a conversation, which is what I love. I love at least talking about it. If even if you don't take any of the tools I have, let's have a discussion. Let's see where you are, and what we can do together.
Well, I think it's awesome that again, I love that we had so much in common and we hadn't actually yet connected. I think we were at a conference way back together, but didn't really meet at that point. And so I would love to connect again. I want to let people know, how to find you if they want to. And then, because again, there's a lot of patients looking for things that we do that don't have access to them in their particular area. And then also about the business and how they could reach out to Humanot if they wanted to.
Well, the easiest way to get anything that I'm involved with is to go to my website, which is Dr. Amy Killen, KILLEN.com. And I have on there links to my Substack. I write a Substack every week, a lot of these topics, and I love talking about it. Links to my social media. I'm on Instagram primarily, Dr. Amy B. Killen, as well as all of my clinics, my Utah clinics, my stem cell clinics, Humanot, my women's longevity supplement company, which is called Hopbox, which is awesome. So everything is on my website, dramykillen.com.
Well, perfect. Well, that is the way to find you then. And again, thank you so much for being on the podcast today and educating me and anyone that might be listening. And again, I think we should deep dive into other things after. And you are traveling and speaking frequently. And so again, just a source of information, and you've been doing this for a long time, an innovator in healthcare, and that is where it's going. So you're leading the way, and thank you so much for doing so. Thank you for taking time out. And again, if you guys have any questions, please just drop some questions in the comments and let's start a conversation there. And again, thank you, Dr. Killen, and thank you for listening.